sustainable development it has many definitions, but it's common. This definition on the screen here is commonly used and was coined by the UN World Commission on Environment and Development. So sustainable development is development that meets the needs of the present without compromising the ability of future generations to meet those needs. And commonly, it's recognized that in order to do that effectively over that period that encompasses generations, then we need to think not just about some of the things we commonly think about in terms of resources, but to look at the resource use and the impacts that we're having in all three of the different domains of economic, social, and environmental sustainability. And if we pay attention to just one or two out of those three, then we might be better than if we hadn't, but we won't be sustainable until we find activities that are beneficial in each of those three domains. But one of the things to consider before we apply this to sustainability to healthcare or to health services is, what is the scope? When we say meeting our needs, do we mean that we should be able to meet our healthcare needs in the future? As in, we should protect the sustainability, the viability of the health service for current and future generations. And this slide refers to the NHS, which is the National Health Service that we have in the UK, but it would apply to any sort of universal health system. Are we just thinking we want to make this system viable in the next 10, 20, 30 years? Now, that is often an easy way in, an easy sell to most people would think that that's quite a good idea. But a larger ethical question is, given that we're working to protect health and promote health in the health service, should we be looking at our wider impacts on health? So if we just go into a little bit more detail on the first one of those, using that triple bottom line, or the three domains of sustainability that I mentioned before, what sort of challenges would we have to consider if we're just thinking about protecting the health service for future generations? So first of all, just some of the economic challenges we might want to think about. We've obviously got a rising demand for healthcare, and in most countries we've got static finances that the increase in the available money doesn't match the rising demand. So we need to find more efficient ways of doing things there. There are also impacts from different types of funding arrangements, international trade agreements and things on the economics of providing healthcare in the future. And I'm sure there are many other challenges in each domain that you could mention, but just to highlight a few. So looking at environmental challenges, is the health service resilient to future environmental changes or even current ones in terms of extreme weather events or changes in patterns of disease that you might see from climate change, for example? What about resilience in terms of transition to a low carbon world? Are we prepared, and do we know what our health service needs to look like for that? And then impacts of pollution and finite resources on the ability to provide healthcare and the demand for healthcare. And then again, a set of social challenges we might consider, things like declining family support, quality or safety concerns in the provision of care. So a big important social group for the health service is its staff. Do we have the right numbers? Are they trained in the right things? And how are they getting on? In the UK, we have quite a crisis around recruitment and retention of staff. And we have quite a reliance on international staff, many of whom are not coming to this country in such numbers as they were before. So those are the kind of things we could look at, and you could argue, I think, to most people working in the health service that there's a good case for considering a longer term perspective in healthcare management, healthcare planning, and therefore healthcare improvement. But I think certainly our health service in this country has made some commitments around protecting and promoting health for current and future generations, and they see sustainability in that light. I've got an alarm going off in the background, but I don't think it's anything serious. Let's stop. Okay, so does healthcare activity currently build health or undermine it? In the economic sphere, I mean, one thing you could think about is we're spending a lot of public sector resources on providing healthcare, but actually healthcare is not the best way of promoting health. There's more important things that you can do around, for example, social support, housing, meeting housing needs, reducing inequalities, providing education and things like that. So there's an opportunity cost from the money that we're spending on healthcare. There's of course the need to manage the impact of having poor health, things like well, any kind of chronic disease, but thinking particularly of mental health on the economy, and various other macroeconomic impacts on health. Social challenges, if we take this broader perspective, we need to think about how we might be impacting on the loss of social capital. Are we, in the way that we recruit, employ people, are we benefiting local communities, distant communities? We need to be prepared for the impact of different family structures and an aging population. One thing that's highlighted in this picture here is that actually, I think many people are unaware, particularly clinicians, that the supply chain for the health system, and I'm sure this would apply to Canada as well as to the UK, actually has some very shocking labour standards, or lack of labour standards throughout it. And you don't have to go too many steps back in the supply chain, particularly of things like medical instruments, glove manufacturer, and a number of other areas to find people working completely unregulated environments. Many surgical instruments are made in northern Pakistan with pretty much no protection for workers. There are many children as young as 7 working to produce surgical instruments. If somebody in the family is injured, then there's no social security net for that family. So then these instruments get taken, I think, in many cases to developed countries, and they get sterilized and packaged there. And by the time that you're taking them off the shelf to use them in your healthcare facility, you would have no idea that that's how they're made. In terms of environmental challenges, I think there's a much greater awareness currently here of the impact of air pollution on lives lost and life years lost in the UK. And it's estimated that there's 40,000 additional early deaths in the United Kingdom from air pollution. But at the same time, we know that the NHS is responsible for 5% of all journeys. And that photo that is just displayed there on the screen is rush hour outside the local hospital in Oxford, where I'm sitting today. And it's regularly gridlocked there. And now that we understand that that's actually causing damage to the development of children's lungs, even affects unborn babies, and obviously anybody with cardiovascular or respiratory disease has a significant impact on their morbidity and mortality. So actually, what are we doing as a health service, running our affairs in a way that is directly undermining the health of our own local population? But more than this, I guess I wanted to highlight the magnitude of the scale of the environmental disaster that we are facing currently. And I think many of you may have joined this webinar because you've become aware of just exactly how significant that is. The Lancet cover shown there is from 2009, and that's a Lancet commission working with University College London, and they identified climate change as the greatest global health threat of this century. And that's the reason for that is that that climate change is not just going to affect the prevalence of different environmental type of diseases, but it's going to affect the ability of whole nations and continents to produce food. It's going to affect which areas of the world are habitable, and it's likely to give rise to, and arguably already does give rise to, significant conflict between nations or within nations. So the knock-on effects of climate change on health are hard to overestimate. And this is a quote from Sir David Attenborough, who's a very well respected and revered naturalist in Great Britain. He said, we're speaking at the UN Climate Change Conference in Poland last November, December. He said, right now we're facing a man-made disaster of global scale, our greatest threat in thousands of years, climate change. If we don't take action, the collapse of our civilizations and the extinction of much of the natural world is on the horizon. And we know that healthcare is responsible for 10% of greenhouse gas emissions in the United States, 7% in Australia, and 5% in England. So it's a significant contributor to the greatest threat that we face as a civilization. That's just in case anyone wants to be able to look up the references from the previous slide. So in the United Kingdom, specifically in England, the National Health Service is committed to 80% carbon reduction by 2050. And what I think is interesting about this graph, which shows in the dark blue line on the left, it shows the historical carbon emissions or greenhouse gas emissions over the last few years. And then it shows a branch point. And what the pink line shows if nothing was done and sort of current trends were just allowed to continue, how carbon emissions would increase. And then there's a series of purple wedges there, which are the impact of agreed national and global actions or expected national and global actions on reducing carbon footprint. So it's not all down to the health service. Some of it's about reducing the carbon intensity of the electric grid and so forth. But then below that light blue line, there's a series of green wedges, and indeed there's a white gap where no actions have yet been identified or mapped out. And those are actions that rely on the health sector itself to take action. So one of the things that's worth looking at here is that in many cases, we're going to be relying on clinical leadership to undertake these actions, because it's not something that somebody sitting in the estates and facilities department of a facility can mandate. Things like shifting away from the metered dose inhalers, changing anesthetic practice, shifting to less intensive models of care, which you can discuss exactly what that means. Public health to reduce system demand, reducing admissions and the need for travel. So all of those things are going to definitely require physicians, surgeons, and all healthcare professionals to contribute. So I mentioned at the start that I wanted to introduce the sustainable healthcare principles of sustainable clinical practice, because when I started working in this area, I found it really difficult to envisage exactly what healthcare could look like with when you've reduced the carbon footprint by 80%. Like in terms of clinical care, what could that look like, and therefore what strategies could we start using to try and get there? And it's clear we know that only about less than 20% of the carbon footprint is made up from energy use in the facilities, so we can't just rely on that. So what we came up with was this sort of logical framework for deriving some principles that we could apply in individual clinical practice and also in the design of new care systems. So we began by splitting into we need to either reduce the amount of activity, or we need to reduce the carbon intensity of the activity that we retain. So thinking through what's possible in terms of reducing activity, without obviously harming patients and aiming overall for an improvement in the health of the people that we're looking after and the population as a whole. So obviously there are lots of different strategies that we could use in order to prevent disease and to prevent the complications of disease. And we know about those in many cases, but that's not to say that we actually do them. And I think there's a huge, huge gap between what's possible in terms of prevention. I mean, after all, the biggest killers worldwide and in our own countries are lifestyle-related disease, which lifestyle makes it sound as though it's all within the individual choices of the people concerned. But of course, we know there are many structural factors that are driving behaviors that are making us unwell, that may need to do with physical inactivity and diet. But we've got a number of strategies, and it will be different depending on what condition we're talking about, that we could bring into play to prevent disease. Now, what I've done is I've tried to choose some examples to illustrate how this could be applied in different specialties. So I think this one on this slide is from anesthetics. So here's an example in terms of prevention. We could be looking to prevent post-operative infections and complications by making sure that the patients leave theatre warm, pain-free, and able to mobilize quickly. Patient empowerment. I think what we're thinking here is that actually the patients are a bit of an untapped resource in many cases for their own care. There's a huge amount we could do to bring them into play, to skill them up and give them the confidence and in many cases the permission to contribute positively to their care. Simple things like the way that we correspond with patients. In this country, there's a tradition of correspondence being between different clinicians and copying the patient. The way that we come up with care plans, whether that's done together with the patient, whether it's set around their own goals, well, that sort of thing can greatly increase or improve the engagement and the activation of patients in their own care. There's also quite a lot of evidence to show that when decisions about people's care are made with somebody who's fully engaged and informed, then their decisions they may take can quite often be different from the decisions that the clinicians would have taken on their behalf. And they can quite often choose less intensive and invasive courses of treatment. And if that's what they would prefer, then it would definitely be valuable to avoid imposing interventions. And it's particularly relevant obviously in people in the final months of their life. So in terms of anesthetics, there's an opportunity to work with patients to get them as fit as possible for surgery, and that can often go on to benefit them long term as well. Lean pathways. So we're talking here about recognizing which elements of our activity in health service are adding value to that patient, and doing our best to design things to strip out wasteful activities. Now, I don't know a lot about the health system in Toronto, but in the UK, where I'm speaking from, there is a lot of toing and froing between different parts of the health system when patients get referred for one condition to one place, another condition to another place. And there could quite often be a loss of information. The communication can let us down. There's not a unified health record, for example, so you end up with duplications or decisions that are made in the absence of the full information about that patient and so forth. So there's a huge amount that can be done there to make things lean. And an example from anesthetics would be around the preoperative assessment pathways, where often there's quite widespread variation in what investigations get done. Okay, so those are a few examples for how we might be able to reduce activity without reducing health and health outcomes. But there's obviously going to be some, at the end of this process, some activity that we think is really high value. We've streamlined it and we want to keep it. We think it's benefiting our patients. So what can we do to reduce the carbon intensity? I think there's two different categories here. One is where you have clinical options available, whether that's for investigation or for treatment, which are we've got more than one option available, appropriate, effective, and you can choose between them. They might have, one of them may be environmentally and or socially preferable. So the classic example of this is in metered dose inhalers. So respiratory asthma and COPD inhalers make up about 5% of the carbon footprint, or up to 5% of the carbon footprint of the health service in England, so between 4 and 5%, and they and that's due to the propellant in the inhaler. It's not due to the drug. So if you buy the same drug in a different type of inhaler, like a dry powder inhaler, then it will have about 1/20th of the carbon footprint. But in terms of anesthetics, there's a couple of examples here. So one is that, again, sevoflurane is about 1/20th the carbon footprint of desflurane, and those drugs are often used interchangeably. Or alternatively, you could change the mode of anesthetic altogether. You could opt for a spinal or regional anesthesia over general anesthetic and avoid the need for any inhaled agents. Now the bottom one, operational resource use, that's a kind of bucket that I've used to lump all the things that are not going to directly change the nature of the care that's received by the patient, but it's more about the behind the scenes use of resources. So different types of equipment, things like this. So the example I've chosen here is the capture and resupply of volatile anesthetic agents, so that you can scavenge the gases and process them to use again. That's something that's being piloted currently here. But it would also apply anything that you did, say, to improve the energy efficiency of the operating theatre suite, like around the air handling and ventilation or heating or anything like that, the waste management. Those kind of things are all important, and they actually do need clinicians to help to drive those through in many cases, working together with the facilities managers, but hopefully the patient wouldn't actually notice any difference. What I have is, just because I had it from another presentation, I've just included some examples from a completely different sphere of medicine. So these ones are from mental health. There's just thinking about what you could do to prevent mental illness, in terms of educating the public, intervening really early when children, young people, or anybody develop psychiatric problems, because that can have a huge influence on the long-term outcome. Patient empowerment, actually many very successful patient mental health interventions rely on the expertise of people who have themselves experienced mental health problems, and they can become a huge asset, and they can help other people to help themselves. Lean pathways, again, lots that one can do to design out waste in the system, stop people bouncing back and forth from different parts of the system, create pathways that build one step to the next. A specific piece of work that was done here at Centre for Sustainable Healthcare with one of my colleagues just looked at the dosing interval of antipsychotic medications, and the evidence base suggests that the best dosing interval was 6 weeks apart for these depot injections, but actually what happens in practice is that they can be given as frequently as 2 weeks apart, and that's obviously more use of drugs and equipment, which make up the largest proportion of the carbon footprint of healthcare, but it's also can lead to overdosing, and it's not pleasant for the patients. Low carbon alternatives. Well, actually, we've got less information here on the carbon footprint of different alternatives within mental health, but you could postulate that things like walking therapies and things like that might be less carbon intensive than some of the drugs, and even talking therapies. operational resource use, I think a big component of the carbon footprint in mental health is travel to and from appointments, because it's largely outpatient based. So actually changing the mode of transport there can have a big impact. Okay, so I guess my question that kept popping back to me when I've been working on this area for quite a long time was, what if sustainability could become a mainstream part of quality improvement? Because quality improvement is one of the most encouraging developments that's happened in healthcare in recent years. Because I think there's previously been I guess historically it was all about the doctor-patient relationship, or the health professional-patient relationship, an individual, and now it's recognized that actually that's not good enough. If you can have a fantastic rapport and brilliant individual practice, but what about the system around you, and what about what happens to that patient when they walk out of your door? And so people are really taking up that challenge and working to spread the skills and the methods and the practice of quality improvement across the healthcare workforce. And actually, I think that's a really natural place for sustainability to sit. People are already looking at the system, what works well, what works less well, and sustainability can be built in there really naturally. And in this country, the Royal College of Physicians in London has said they also believe sustainability is a characteristic of healthcare which must run through and moderate other domains of healthcare and healthcare quality. And they've explicitly said that this is not just about the sustainability in terms of financial sustainability, it's in terms of the broader understanding of sustainability. I think when you take that perspective, you can kind of see sustainability as a domain or a dimension of quality. And you may be not sure, I think we've got quite a mixture of people on this webinar, but I think many of you will be familiar with the 6 domains of quality: safety, timeliness, effectiveness, efficiency, equity, and patient-centeredness. And then sustainability kind of fits right in there, and many times it can strengthen the others. And that's something that, as I say, the Royal College of Physicians has embraced. And I think that one of the things that's very powerful about that is that once you look at sustainability as an element of quality, then that means you're, it should also follow that it should be part of quality improvement. So this is what brings me to the SUSQI framework that we've developed here. This is an attempt to put together some guidance on how sustainability could be integrated into mainstream quality improvement methodology, rather than it being treated as a separate thing. And when you do that, it changes the aim of quality improvement to bring in this broader perspective. And it's based around, this is a kind of wordy version of the equation that's shown here, which is at the kind of heart of the article that's referenced on the previous slide, which is that our goal is to maximize the sustainable value. And that means we've got to maximize the outcome, the good health outcomes for patients and populations from the use of environmental and social and financial resources and from their impacts. So we've kind of taken what might be quite a conventional value equation, which would be outcomes over cost, but we've broadened the costs to include environmental and social impacts alongside economic. So just to show you how it fits into a sort of mainstream generic quality improvement model, one definition of quality improvement is that it's the ongoing systematic effort to improve patient outcomes and system performance. And it generally, there are many different quality improvement models, but most of them have these steps included within them. So they would include some phase of setting aims, establishing measures, selecting changes, testing those, implementing those changes, and then spreading them. And I've just asterisks on this slide on this list, some of the steps where we think that sustainability could be logically integrated. And then they're mostly in the design and the selection of the change. Then you would go on and test and implement those changes using the PDSA cycles as you normally would. Then at the end, I guess the other big change is that when you come to evaluate the quality improvement initiative, you would evaluate against that. So I'm just going to go back one slide, against the different variables in this value equation. So you'd be looking at what were the outcomes for patients, what were the outcomes for populations, what were the environmental, social, and financial impacts. And you're not going to kind of convert it all into one number at the end, but I think it's something that could be become a standard framework that when you looked at a quality improvement project that had been written up, you say, oh, right, well, what were the outcomes for patients and populations? What were the environmental, social, and financial impacts? And the more we do that, the more, the better we'll get at it. So this is essentially the SUS-QI framework. So on down the left-hand column is the element of mainstream kind of QI methodology. So which is sort of paraphrasing the list on the previous slide. And then if we just go through that, so with setting goals, we would include sustainability explicitly, as we did when we changed the aim of QI to be about maximizing sustainable value. When we come to the bit about understanding the current system in order to be able to focus our energies on where the problems are, and then number 3, designing the improvement effort, I think there's quite a lot that gets done currently to map out processes and see what all the different steps are that are involved. And that's quite a natural place to look at where the resources are being used and where some of the social impacts are occurring. I've talked in quite a lot of detail about the designing the principles of sustainable clinical practice. So I think these could be applied in the sort of systematically as you go through to design the improvement effort. And then at the end, when you come to measure impact, you go back to that equation, as I mentioned. And down the right-hand side here, it's just listed some benefits, because I think we have seen from our experience that there can be additional benefits sort of directly to the quality improvement process in terms of the engagement of people, clinicians, and health professionals in the healthcare improvement, also sort of stimulating slightly more radical creative thinking, future-proofing, directing people to, put their efforts into the highest value changes. And then just that broader perspective does really allow you to communicate with a wider range of stakeholders, I think, and make sure that the patient and the carer and community perspectives are built in, and the staff perspectives are really built in rather than added on. I think sustainability can be either made the main focus of a project, so you could choose a project area that relates very closely, like looking at any one of those 4 principles, reducing pharmaceutical waste, looking at particularly at overuse of low-value interventions and investigations, that kind of thing. Or I also think there's a place for applying sustainability systematically in any QI project, even if you're not coming from an environmental perspective at the outset, or also social. Okay. To go alongside the framework, there's a number of open access learning resources, which we can also share this in the chat. They've got a number of templates in them, so these are just going to flick through a few templates that might be useful when you're looking at working your way through the process of setting up a QI project, identifying scanning for social impacts, and then choosing outcomes for the ones that you think are important, annotating your process maps and highlighting the common impacts using those principles of sustainable clinical practice. And there's some sort of blank driver diagrams and things that you can use in there, and quite a lot of guidance on how to measure carbon footprint and so forth. So the last thing I wanted to do before I wind up in just a couple of minutes is to just talk you through an example which has arisen out of one of the programs that we run here at CSH, which is where we go into hospitals and engage with staff teams in the clinical areas to develop a sustainability project. And the purpose of the Green Ward competition is to engage the clinical staff and help them see that sustainability is for them as well, and what it could encompass. And it's run over a period of a few weeks or maybe a couple of months, and we go in and do a workshop with each team, help them think about a project, design a project. We also encourage them to look for projects that will score well on the sustainable value framework, and they will also to help them to evaluate some of the impacts. So just one example from Exeter, which is a town in the southwest here. We were working with the emergency department. These are two of the staff members from that department, and they were thinking what to focus on. And in the workshop and in conversations, drew to their attention this information displayed here in the graphs. If you look at the green columns at the back, that's for the acute care sector. And look at the tallest spike there, that's the procurement of medical instruments and equipment, which contributes a big chunk of the carbon footprint of the acute sector. And they thought about the use of equipment in their department, and they thought that actually a large number of patients are cannulated, and quite often those cannulae aren't used. And they thought about all the equipment that goes into setting up to cannulate somebody, and sometimes doesn't go in on the first attempt, and then at the end the sharps obviously have to be disposed of responsibly and so forth. So that might be an opportunity. So they identified some measures to track the progress of their project. So they counted the number of cannulae inserted each week. They got staff to record it as they were doing it. And they also recorded whether each cannula was used while the patient was still in the emergency department. They then ran a campaign which had various elements, basically to engage staff and to think about whether the patient really needed to be cannulated. And they audited for a week, then they ran the campaign for a few weeks, and then they audited again. They found they'd achieved a 59% drop in the total number of cannulae inserted, and a 66% reduction in the number of cannulae that then didn't go on to be used. They didn't measure the impact on patient outcomes because it was quite a small intervention over a small time period, but we postulate that there is a potential for reduction in infections. But there are a lot of other impacts that fall more into the social, environmental, and financial areas. So, for example, reduced pain and distress from being stuck with a needle, reduced physical restriction from being hooked up to IV fluids and so forth. I mean, that was one of the things that was also noted, was that once there is a cannula in, then there's a sort of tendency to put IV fluids or IV drugs when the patient could actually take them orally. And if you imagine when you're hooked up to a drip, then it's quite difficult, for example, to take yourself to the toilet. So it can have quite a few other knock-on effects. We were able to calculate an environmental and a financial impact fairly simply. I think we just took the two most expensive pieces of equipment used, which was the cannula and the bionectar they were using, which is some sort of connecting thing, and they multiplied up the cost by some greenhouse gas emissions factors, which the resources that I've mentioned can give you some signposts to where to find these, but you can get these, they're publicly available. So you can multiply the emissions factor by the cost of the surgical equipment or medical equipment. And also there's another emissions factor for waste incineration, and you can multiply that by the weight of the equipment that you've used. And I worked out at 161 kilograms of carbon dioxide equivalents and 533 pounds saved per week. So that's an example, and then I hope that stimulated you to think what might be possible in your setting.